your normal documentation. So in conclusion, we want to assess frequently. We want to anticipate painful procedures. We want to remember to treat them prophylactically, okay? And hopefully you guys walk away with that thinking that, well, they said they're not in pain, but I'm just gonna go in and do a Dignacare and a Foley and a Dophoff tube, and you're not gonna give them anything for that? It's just mean. You're gonna monitor these patients for side effects, for sure. In our ICU, please use the least sedating medications first. And do not discount different routes. Margie is a brilliant nurse, and she has always been sort of a nursing idol of mine, and she's a big fan of using rectal Tylenol. And doggone if she's not right. It's quick acting. Tylenol is a medication that's in pretty much every narcotic that you can think of. It's all got Tylenol, and it's a great medication. But when we give it orally, it takes so long to take effect that the patient doesn't really notice it, and then we say, oh, it wasn't effective. But I've used it a number of times. I go in, I give it rectally, and within 10 or 15 minutes, patient's resting. And that's about it there. So, let's see if I can find
What's the
one.
most painful procedure?
The most painful procedure. Let's see if I can find it. Maybe I took it out. I did, I think I took it out. The most painful procedure reported in several nursing journals, but one, the article that I got it from was critical care nurse is turning. Turning. And we don't even think about that being a painful procedure. But when people walk out of the hospital, I would have said suction, I would have said art lines, I would have said pokes. But I think turning stands out in their mind because we do it so frequently. We do it every 2 hours. And we're pretty uncaring when we do it. I think we try to do our best, but these patients are not light often. And if it's me in there turning these people that are 400 pounds, it's gonna be a, ugh, here we go. Slammed into the side rails, you know, we're patting on your back, and we're doing all these interventions for them to make them better, but we're doing it in a way that I think we wouldn't really treat our animals, if that makes sense. Anybody have any questions?
Hey, how do you know you're not treating yourself when you're treating the patient? You know, you brought up about the fact of you know, restlessness and things like that. I mean, I think every nurse has their own way of picking up information from patients. For example, back, okay? We all know backs take a lot of medication. Some of us will try very hard to get that SR on board, Robaxin on board, and we're throwing meds at them because they're going, they're 15, it's 15, you know. And
They're the bleeding eyes one.
Huh?
They're the bleeding eyes.
Yeah, right, you know, and you say, oh, you know, this is all gonna tap out, it's gonna be out like a light, you know, I mean, so how do you know you're not treating, you gotta listen to the patient, and you're treating the patient.
Preconceived notions.
Huh?
You have to look at your own preconceived notions,
Yeah.
I think is what, my understanding of your question.
Oh, I'm just concerned about over sedating, and yet, you know, the pattern has been that when, like when I have a back, I throw everything at them, my mornings are better, you know, and not out of it completely.
I think that you have to be smart about the medications that you're using. I think that you start, again, least sedating first. We frequently jump to the narcotics because we assume that those are the better medications. They're not always the better medications. From personal experience, going through multiple dental surgeries to get these nice pearly whites that I have here that are all fake, I can tell you that Vicodin was not the best option for me. It made me very ill. It made me pass out for several hours, and it didn't do anything for my pain. What helped me was Motrin. So these are situations that you may want to involve the family and say, you know, what, has he had pain before? Is he have chronic pain? What does he take at home? Is he sensitive or is she sensitive to medications? Families have a lot more information than you know. If it's a back patient and they're neurologically intact, you have that conversation with them. So what have you been taking at home? You'll find often that you are not going to oversedate these patients because they take so many medications. I took care of a back patient once, and I can't remember which, it was an oral morphine that we were giving them. And we had to go in with 16 tablets at a time because we did not carry the amount, the milligrams that he took at home. 16 tablets. I will never forget counting that out and calling pharmacy 100 times and saying, are you sure 16 of these things? And it, sure enough, it was. I think it was, each one was 10 milligrams or something, and it was like 160 milligrams that this patient took. Back patients are very different ball of wax. They're chronic pain people. I can almost guarantee you, you're not gonna over-sedate them. But start light, work your way up, use those non-invasive, non-narcotic interventions, sort of sandwich it. So I'll give you a narcotic, but then you need to let me reposition you. I'll give you another medication, but then why don't we try a little bit of music? Well, you're still uncomfortable, so let's try another medication. However, I'm gonna go ahead and bring your wife in to sit with you now. Just sandwich it, layer it, make sure that you're looking at the patient holistically, and meeting all of their needs, because fear, anxiety, being too hot or too cold can make that pain seem 100 times worse than it really is.
When did they stop doing Robaxin scheduled post-op? I remember giving it, was it like 3 times a day or so many times a day times 3 days? I mean, my old person remembers that.
I don't remember that.
Robaxin being a scheduled med?
But then I will tell you that I avoid back patients, like,
I remember it being,
Yeah, I remember it being scheduled.
I don't remember it being
See
scheduled.
it as a PRN.
But see, this is the
Because
whole
it's listed
reason.
on the PRN and then people don't like look
see
all the way,
it.
they look at the oxycodone, the morphine, they kind of leave that behind and then all of a sudden.
Perfect,
You
exactly.
realize it's still there and
I agree, and there's a lot of other
you get a lot of relief
medications
from it.
that are great medications that we don't use frequently enough. Ultram. We don't use it frequently enough. Why don't we? Tylenol. I'll see somebody getting, oh, I've been giving them 100 mics of fentanyl every 2 hours. Well, did you give them Tylenol? Well, I didn't think about that. Tylenol's a great medication. It's in every narcotic. Think of a narcotic that doesn't have them. You know, there's not a ton. And the reason that they put it in there is because it works. Headaches. Good old Phyllis. What did she always say? Vicodin and a cup of coffee. And I'm telling you, Excedrin has caffeine in it. That's why it works. The only thing that makes Excedrin different than every other pain medication that's out on that shelf is it's got caffeine. And if you have somebody that is like me, that drinks 3 or 4 cups of coffee a day, and on top of my brain bleed, I'm not getting my caffeine, you're gonna get a caffeine headache. I'm gonna be miserable. And occasionally it's appropriate, talk to the physicians first, but sometimes back on 4A, it was not out of the realm of possibilities when we had took care of a otolaryngology patient to give them a little bit of coffee in their drop-off tubes. We used to give them beer. I don't know if they still do that.
No.
We did, because we were not gonna fix them. We weren't gonna fix their alcoholism in the week that they were here. And instead of giving them the Haldols and things that we give now, we would order, and it was like this gross, weird looking bottle of beer, and we would give them beer in their drop-off a couple times a day to help ward off DTs. I mean, we used to have people wander out and be like naked at Wendy's, so I guess it was, I don't know if it worked all that well. Good old Jim, that's where we found him, naked at Wendy's. And nobody said anything, that was the really weird part. Good old Jim was completely naked, ordering a cheeseburger at Wendy's, and nobody said anything. They just stood in line next to him like, it's kind of strange. I love Nero. Does anybody have any other questions? And I mean, I'll suggest, if this sparks anybody's interest, like talk to your colleagues, get a little committee going so that we can be consistent on our unit. We are very bad at documentation, we are very bad. And that's not Gail, Gail's out of here. But anybody who is interested, who's looking for a level D or E project, heading up a pain council would be huge, would be huge. You can meet once a month, you can review charting, you can see how well we're doing on pain treatment. It is a quality indicator as well, which is huge. It's keystone. Pain, we look at skin, we're great on skin, we're great on VAP, we're great on, not restraints, not so great on that, but, you know, it's definitely something that needs to be addressed on the unit.
Do you think people that fill out the questionnaires, because I've seen some of the questionnaires, and they have not said pain wasn't adequately, I was wondering if those are the ones that don't fill out the questionnaires, you know, usually it doesn't, I haven't seen pain as an issue of, you know, not getting.
They don't remember being in the ICU.
That actually, that is Angel's
Or they
right.
suffered the whole time they were here.
Angel's absolutely right. How often do you get a patient that comes up to see us 6 months after admission and they have no clue who you are?
Oh,
Yeah,
that's
they don't
true,
remember
yeah.
being.
They don't
here at all.
remember being here, nothing looks familiar to them, and their family member's like, oh, look, you were right there. They have no idea. So when we do propofolize them, I'm gonna make that a word, propofolize, we are taking away some of their memories, and they go